We'll call the September 3rd meeting of the Planning and Oversight Committee to order. Call the roll, please.
Mr. Arnold?
I'm here.
Mr. Albright? Ms. Banks? Here. Ms. Bell? Here. Mr. Brown?
Here.
Ms. Carter? Here. Ms. Clark? Dr. Elhide? Ms. Friedman? Reverend Gordon? Ms. Harding? Here. Ms. Howe? Here. Ms. Mendoza-Locke? Here. Ms. Rodriguez? Dr. Sadat?
Here.
Major White? Ms. White?
Okay, have folks had a chance to look at the minutes of the August 6th meeting? Are there any additions or corrections? If not, let's approve them.
You need a motion?
Yep.
So moved.
Thank you. Thank you. We have a motion and second. Any further discussion? All in favor say aye.
Aye.
Any opposed? Any abstentions? The motion carries. Okay, so we're starting then on the top of page 3. Jenny is going to start us off.
So normally in September, I bring you the year-end financial statements for the year before, but we have a couple things, well, I think just one, POS for fiscal year '24 later in the packet that would affect the financial statements for last year. So we don't have the full financial statements yet, but I have a summary in here of where I expect us to be, just so that you kind of have big picture so you can use it to make the decisions later on. So you'll see at the top of page 3, there's a lot of numbers in that teeny tiny paragraph. So I'm just gonna kind of go big picture on it. I expect to be under budget for both revenue and expense. Revenue at about 31.3 million on a budget of 32.5, and expense 35.1 on a budget of 38.5. So a loss of 3.8 million versus a budget of a loss of 6 million. Then I also have in there what we had forecasted. So we're actually much closer in the forecast than where we were against our budget. So the forecast we had budgeted, or in the forecast we had revenue at 33.7 million and expense at 38 million. So a loss of 4.3. So our difference between the forecast and where I expect actual to be, should you approve the POS later, is only 200,000. And that is just big picture. The difference is going to be the POS that you're going to see later was not in the forecast, so it's significantly over budget, over forecasted what we thought. But we had a lot of other areas that were under, because of our intentional underspending. Like we've talked a couple times about our health equity underspending. We had some strategic planning underspending that we had taken internally in order to save funds. So overall, we're gonna come very near to where our forecast was, but keeping in mind that our forecast still showed that we were going to be deficit spending and losing money throughout the period. So that's big picture. I'm happy to answer any questions if anyone has any.
Are there any questions for Jenny? People need a minute to absorb that.
This was for informational.
What is,
I understand. We're not going to vote on this.
what does the forecasted loss include?
There were several things in the forecasted loss. Most of it was, I mean, just in general, spending over revenue in grant-funded programs, POS programs. We did have the legal expenses in '24.
All right, well, if you do have questions as they come to you, we're gonna, I think, in a couple of minutes, we're gonna begin to something that will again involve where we are financially. And if you have questions, with you, feel free to bring them up then. Okay, the calendar year audit, Jenny?
So that is in the middle of page 3. We are part of Lucas County, so we are part of their big audit for the whole county. And we submit to them all of our expenses, and since they're all paid through them, they have all of our detail. And they run on a calendar year. So this is a result of calendar year 2023 audit. So we were selected as, several of our programs were selected as major programs in the federal testing. The ARPA, which is through the City of Toledo, and the Hospital Access through OMAS. The Title 20 and the SOS programs were all selected as major. So I did just want to point out that we had over $7.8 million of federal funds that we spent in calendar year 23, and they tested in detail almost 4.2 million of that. And they did not have any written findings or non-compliance for our funds. They did, however, have a verbal comment related to the information that we provide to the subrecipients on our notice to them. So they wanted us to include a little bit more information, and we already made that change and resubmitted some of the fiscal years 24 to our provider agencies. If you wanted to read the full audit, you can see the link in the, I think it's the last sentence there on page 3, and I can answer any questions anyone else has.
Anyone who's having trouble falling asleep, I recommend that audit to you. Very helpful. Well, that's good that we had no management letter, no nothing.
Correct.
Yeah, that's
Correct.
great, Jenny. That's really, those of you who serve on boards and know about audits and have lived through audits of nonprofits, that's a very good result, so thank you for that.
So
Any
the language
questions?
The language that was for the subrecipient language, notice language, whatever.
Mm-hmm.
What was that? I mean,
Yeah,
in
they
general?
actually, because I figured someone was going to ask. They wanted us to include on our notices, we did not have the FANE, the Federal Award ID numbers, and the federal award dates. Because, and I knew about the federal award date. I said, well, we don't get it directly from the feds, we get it from OMAS. So we had a little bit of back and forth with the auditors on that, because I said, how do we know the federal award date? So this is why it was a verbal comment, because we had some back and forth on it. But we included those, and we included a couple other things too, because we, in this, realized we were missing some other things, but.
So it was data that we, or information that we have, it just was not.
Correct. Yep.
Okay, any other questions or comments? All right, thank you, Jenny. Now, the purchase of service, I think we've raised this before, and it's time to grapple with it. So Jenny, you want to explain what's happening?
Yeah, so Scott touched on this a little bit a couple weeks ago in his director's report about the need for additional purchase of service funding. For those of you who are new on the board, this is our treatment funding. We've seen, in fiscal year 24, we've seen an increase in the number of people served, as well as the increase in rates from, the Medicaid increased their rates as of January 1st, and we mimic those rates, so we increased our rates as well. So you can see in the write-up there that Zeph Center, New Concepts, and Unison have already submitted claims that have already gone through the process. They're fully approved claims, but they have exceeded their allocation of funding, so we haven't been able to pay them. And then, so we went through and estimated based on current trends and past billing trends with what they have submitted and what they would yet to bill, the total amount that would be needed to fill fiscal year 24 claims. And you can see there for Zeph Center, it would be $337,000, for Unison, $76,000, and New Concepts, $286,000, for a total of $699,000. As I said before, this was not in the financial forecast. We had actually forecasted underspending of $700,000 in the forecast. So when you look at the difference between, for POS specifically in the forecast, we were at a about 4 million in the forecast. If we were to pay this out, we would be at about 5.1 million in fiscal year 24 POS. I have in there, I think, a little bit more information about what it does with the forecast. Because of what I said before, overall, this would be over in the forecast. Some of the other areas were under in the forecast. But we know that the increase in POS is not sustainable. So we have already begun communications with the provider agencies that we are comfortable paying fiscal year 24, provided you all approve this, but that going forward, conversations need to be had about where we go from here, because we had already, the Medicaid rate increases were only as of January 1st, so that was only half of a year. So looking forward into fiscal year 25, it's gonna be a whole year of that. So if you compile half a year last year, this current year, we're gonna be looking at a full year. Plus, we already decreased some of the allocations from 120-day notices. And, just a combination of a lot of things that are going on. We know that conversations have to be had because we can't financially sustain covering all the claims going forward. So we have already begun, I believe, scheduling conversations with the providers about how to best handle where we want to go from here in fiscal year 25. So we have here the increases for fiscal year 24, and these would just come from our undesignated fund balance, as I said, because we do not have it in the forecast. And I'm happy to answer any questions. There is 3 motions there on page 4 for your consideration.
And Jenny, I know that my question probably is for the program staff, but can you help me out a little bit by defining the service provided by each of these entities? I know that was there for the crisis. What is the purchase of service that that caused this?
So the crisis is actually separate, so that's under their own, a crisis grant.
Okay.
So this would be the other treatment that's provided.
So yeah, that would include things like diagnostic assessment, therapy, group therapy, case management services. They're all billed by the time spent with the client.
Time spent with the client, but does that mean, with the DAs, does that mean that there's a uptick in the intake? Or
Yeah, that could be an uptick in intake and increase in amount of services. So a person could be getting several hours of case management a month, or going to therapy weekly instead of every 3 weeks, for instance.
So I have a question, to piggyback on that. So if the majority, and I don't know this for sure, but the majority of their people have Medicaid, this seems like, wouldn't that cover most of it? Because I know they do cover, therapy and case management and all those things. And so I'm just trying to figure in my head to figure out how we got like this big of a number. Are there really that many people? Is there, I guess the services that are being covered. I guess that's what I'm just trying to understand.
Well, let's separate Medicaid and non-Medicaid, because
Okay.
Medicaid pays Medicaid claims.
Right.
We don't pay Medicaid. So
Right.
this is all individuals that have been identified by our contract as eligible for board-funded treatment services.
So that's a special.
So they're clearly the folks that we cover. In years past, about this time every year, we would come to you and ask for additional dollars to offset the Medicaid overage in some. Some agencies have overage, some agencies have under. And it usually balances itself out. What we're seeing is more people gaining access to treatment services, which is what we want. We want more people in treatment services, right? So the things that we're doing are working in helping folks identify treatment. And these are non-Medicaid recipients. So they're people that we cover. What we're requesting here is additional funding to backfill those 2024 contracts to pay claims that have already been processed. According to history, we've always covered those claims. We are contractually not obligated to do that, but it's bad form. And I would, if we want people to get care, get quality care, and have and affirm our priority of access to treatment, then this makes sense to me.
And I understand that part of it. I guess I'm just trying to figure out like how, what can we do if there's this many people though that we have to cover because they don't have insurance? That's just kind of what's going on in my head.
Yeah,
so.
and it's going on in our head too.
So that's just where my question is
So
coming from.
a little history would be helpful, I guess, in this case. There was a time when all the agencies that had a board-funded treatment contract had to manage their contracts to the dollar because there wasn't any additional funds to pay any overages. That time, we haven't had to do that since 2011. We passed the new levy in 2012, and we were able then to increase the POS allocations and then cover any overages from our undesignated fund balance. So historically, this has been the case where we would have had benefit limitations up through 2012. And of course, we haven't had them since that time. There is a conversation needs to be had about what type of benefit limits do we think are appropriate, if any. So within the system, funds are there. It's just where do you want to take them from? Because as Jenny's referenced, they are not in the budget forecast. So anything that isn't in the budget forecast has to be taken from some other program, some designated fund already. Yes, ma'am.
I have a question. So for these three that you're giving the money to, should it be a cap on that? Or would that be a cap on services rendered, because the services have already been rendered?
So services have already been rendered, but by contract, we accept claims within 365 days because that's what Medicaid does.
Okay.
So we need to make room for if Medicaid reverses a claim because the person wasn't eligible, but then they become eligible for us, then we pay that claim. And vice versa, it goes back and forth like that. But typically, after the first couple of months from the end of the fiscal year, we don't see a large uptick in claims processing. What we see here is kind of close to where we'll end up. Give or take a couple thousand, I guess.
So you're servicing more people?
Yes.
And it seems to me that one of the principles here is not just bad form, but it's in our best interest to be involved in the conversations with the agencies about how this is going to get solved. And if we just simply said, we're not going to pay you, go figure this out on your own, when we came knocking and said we'd like to be involved in that conversation, they'd say, where were you when it was time to pay up? So I think it's in our best interest to engage in this.
Yeah. I mean, there's, Nima, you had a question.
Help me refresh my memory here. At one point, we talked about doing some incentivizing our agencies, and I don't remember, I think Zeph might have been one that we were incentivizing, but I don't remember about the other two. And I guess my question is, does this, what we're finding as these increases, these overages, do those in any way impact our incentivizing or incentivization of the services and programming where we're going to have additional payouts? Does my
I
question make sense? And is
I
it-
think I got it.
Okay, all right.
So the value-based purchasing contract is for crisis services.
Okay, so unrelated to this.
So it's for, yeah, unrelated.
Okay,
But if they're doing, everything that, you know, and they are, by the way,
Yeah.
meeting all those incentives, it's very logical that more people are engaging in treatment out of the crisis system because it's working properly. So in a way, it could be leading to this, which is, again, a good thing.
Good
Right.
thing, yeah.
And not all people come through crisis.
right,
But also, you know, we have the app now.
right.
And there's a lot of community awareness around treatment. And, you know, here we are sitting 2 years post-COVID.
Right,
And we're starting to, you know, I think the community conversation is driving people to treatment.
right,
And we're seeing more people that are in our catchment of 139% of poverty to 250% of poverty.
right. So there may be some unanticipated benefits / financial obligations flowing out of that.
And that's fair. That's a fair statement. And I think that, again, that's all positive because that means
Oh,
more
yeah,
people
no,
are.
yeah, no, I'm
yeah.
not suggesting it's
No.
not
Yeah.
150% positive. I'm just trying to conceptualize what's happening.
It's gonna be a difficult problem, difficult conversation, difficult problem to solve, but we've gotta do it.
So just kind of perspective-wise, our contracts have a dollar amount that is initiated within the contract for purchase of service. There is no obligation for the agencies to continue treatment services beyond that dollar amount. So they are and have been, they've looked in the past and said, okay, you know, and we've sent them some signals that say, hey, we're going to present this because we want people to continue getting treatment. I think it would be a really bad form to pass a levy in March and then not fund continuing treatment services. But that doesn't mean that we have to tie ourselves to that public policy moving forward. There's got to be a conversation about what can we do to ensure that the flow of new people into treatment continues. Everybody gets a little bit of something. The people who need it more, get more. The people who need it less, get a little less, so that we can spread that all around. Without bankrupting all the other programs that we have initiated. That means we have to take a hard look at establishing benefit limits. Now there needs to be a discussion with all the providers around what that looks like, because it might look differently at Unison than it does at Harbor. That's why we need to have those individual conversations. Right now, I don't think we're at a place at the board level where we're going to say, we're going to restrict this service to 3 per year, or you can only get 1 detox per year, or you're going to do this. I'd rather have that conversation with the providers and say, we need you to manage to the dollar, because we just can't continue these large increases. So that's really where the conversation, I think, needs to be had.
What's typical for the detox? You said more than 1 a year.
Well, I mean, it's not, there isn't, I was using that as an example,
Okay.
but there isn't a typical.
Okay.
And I guess the other question I have is there a way for us to know, to get ahead of the ball so that we know on the front end rather than the back end after services have already been, you know what I'm saying? So that we're not hit, or there isn't a number announced 6 months or a year down later after services have been.
We know the trending. Jenny and her
Okay.
team manage the trending, and we look at it. And
Okay.
so we knew third quarter that actually, it might have been second quarter,
Right.
that New Concepts was trending way
Yeah.
above norm, and third quarter when Zeph Center was.
Okay.
The Unison is coming in right at a place where a swing either way, it would be difficult to.
Okay.
We know underspending as well, trending. So
Okay.
this wasn't a surprise to us. We held on to it, trying to figure out what the full extent is so that we would only bring it to you once.
Okay, all right.
And I really wanted to see how year-end was gonna play out before we brought you a full conversation, because it would be irresponsible on our part to come before you and say we need $700,000 when I didn't know exactly where year-end was gonna be. So if we were in the third quarter and I said we needed this, and without having full knowledge, it didn't seem to make sense.
A lot of people show up and they don't have Medicaid, but maybe they qualified for it. At the time they do their intake and their assessment, do they count that as a Medicaid or do they count it as?
So our contract says that we will cover individuals who look Medicaid eligible but don't have a determination letter up to 10 days from first point of service. At which point a Medicaid application has to be submitted within that 10 days. If they do that, we will fund another 60 days, I believe, of treatment service while the determination is being played out. Our contract also says that once you submit the Medicaid application, it has to be retroactive to the first date of service. So all of that is, as of now, all of that is reconciled behind the scenes. So if we pay a claim that for someone who appears to be Medicaid eligible but lacks a determination letter, and they get that determination letter retroactive to the period where we paid that claim, all of that will be reversed.
So if somebody's on Medicaid and say 6 months or 4 months into treatment, their income's better and they're no longer qualified, does anybody go back and relook at it?
Oh, yeah, that's done constantly.
Okay.
It's done on the Medicaid side and it's done on our side.
Okay.
Can I ask one question, Scott, just for clarification? For these are which Medicaid has been or has already been billed, and there is no,
These
or
are
there is
non-Medicaid.
not,
These are our covered lives, so
Okay.
people that we're responsible to pay.
so the only reason I'm asking, and this was that, so, because I've also got bills for someone, because I have someone personally that's receiving Medicaid where they have sent bills, and I've had to call back and say, hey, you did not bill Medicaid, so I'm just making sure that we do make sure that of course, to make sure that they're also following back up on that billing is going through. And I'm not saying it's their fault. I know that there's third-party billing helps that the Medicaid, that the billing is going through, that some things aren't falling out. And it's a simple fallout on the system that's happening. Just happened for us a couple times. And I'm not saying all over, and I'm not trying to say that, just making sure on our side that we're checking that too, to make sure that things aren't falling out.
So I can't speak to your case, but
Right.
I can say that the systems, they automatically reconcile, so.
Okay.
So
So I just wanna make sure.
whatever billing we get is bounced off of, are they a Medicaid eligible person or not?
Okay.
And if they are not, then we pay the claim. If they become eligible with a date previous to the claim we paid,
Okay.
that is automatically reconciled. and
Okay.
We basically offset it against future payment.
Okay, that's why I just wanted to make sure of me make that call. Thanks. It's just something that helps me clear up that. Thank you.
I have a big picture question. So if the need for our services that are uncovered increases, but Lucas County population has not increased in proportion to that need, we are assuming this is a good sign because of improved access to care, right?
that's what.
But at which point we would know that this is a bad sign and there are more people having mental problems because of loss of employment or crime or whatever. Is there any sort of indicator where we could tell what's the limit? What if the needs increase every year? Is that always a good sign?
Well, that's a good question. I'm not entirely sure on that. I would think our prevalence rates are typical for mid-major cities, you know, in the Midwest. But I haven't looked at it in that respect. We're going to have a conversation at the end of today around the performance metrics, where Julie will talk a little bit about some of the high-level metrics that we monitor. And I think that your question is well stated, and maybe that's something we think about looking at in the future. Because you're looking at it as, is there something relevant in our community that has caused us to bump up higher than the per capita norm of individuals seeking behavior?
That we can work on
Right.
a preventative way.
That makes sense.
Any other questions or comments? Does anybody object to taking all three motions together? Would entertain a motion to recommend these to the board. Is there a second?
Second.
Is there any further discussion? All in favor say aye.
Aye.
Any opposed? Any abstentions? Motion carries. We should make sure that our contract has a non-waiver clause so that it's clear that this is a one-off and it doesn't set a precedent for the future. Okay, Elijah, access to wellness funds.
Good afternoon. I'm on page 4 at the, towards the bottom. The Access to Wellness Funds, this is a program through Ohio MOS that we get an allocation for. It was formerly called Multi-System Adult Program. I think that kind of lends a better understanding of what this program is, but basically it is to engage people with multiple hospitalizations or stays at the CSU or currently incarcerated or in competency restoration to help them stabilize in the community. So we get these funds from the state, and agencies that we contract with are able to make purchases such as pay for rent, buy food, buy clothing for this population. Last year, I just looked, we served 46 individuals with, I believe the highest need was to pay for rent at different group homes or their own apartment, and then other things like food. We paid for some hotel stays. It's really, the program is really based on clinical need for these individuals. So, and in the middle of page 5, there is a motion for your consideration.
Are there any questions for Elijah or any comments about this fund and the motion in the middle of page 5?
Elijah, help me, who administers the program?
So we will send out contracts to all of our treatment providers, the Guardianship Board, and St. Paul's Community Center, who then make the purchases and then we reimburse them for it. So myself and finance will review all invoices and receipts to make sure they're eligible purchases, and then we'll process those for payment.
When you say purchases, you mean you're buying purchases for them?
So that's the rent, food, clothes. Those are kind of big ones.
Any other questions or comments? Entertain a motion.
I move.
Second.
We have a motion and second to recommend to the board approval of the motion in the middle of page 5. All in favor say aye.
Aye.
All opposed? Any abstentions? Motion carries. Better late than never. The chair would like to recognize the visitors that should have occurred several items ago. So Richard, could you start, please?
Jason Pollock, past all Louis Recovery Council and St. Paul Community Center Board of Trustees.
Latrice Flowers, board staff.
Thank you. All right, Scott, you have the Hospital Access Collaboration Program?
Yes, so let me draw your attention to page 5, 6, and 7. I wonder which is hit you with that. There you go. We're all out of sorts today. So, I want to just talk to you a little bit about what the plan is, and then the preceding motions will execute the plan. So, we have been meeting as a group, a collaborative, so to speak, for months now, talking about issues related to municipal courts and their individuals that are referred for competency and found unrestorable, who may have violent tendencies in the past or maybe an active violent charge now. Nonviolent folks typically can't get access to the state hospital, and these folks also languish in jail because we have problems getting them in the privates, and oftentimes they serve their time out in the jail and are released without much hope of any care at all. It's a large community conversation, and it has evolved to a discussion about what can we run as a pilot using existing funds braided together to see if we can create a mechanism where folks can get better care than what they're doing right now. So this actually started out with a conversation between St. Charles and the board after many, many meetings around competency and outpatient competency and all that fun stuff. We approached Court Diagnostic and Treatment about what they might be able to do to help us manage this process a little better. Because if you're referred to competency, you're actually referred to Court Diagnostic for the competency evaluation. Then they render their judgment and provide it to the courts, and then the courts decide what they want to do. Toledo Municipal Court has probably is impacted by this more than any others just because of the sheer volume of folks that are rolling through there. They have started to take the stance that if somebody becomes incompetent and is found unrestorable, that they will dismiss the charges and then file an affidavit in the probate court for hospitalization. Now, that happens, but just because probate might order hospitalization doesn't mean there's a hospital willing to take them. And you're not getting into the state hospital. So, conversations around what we could do with St. Charles, Mercy St. Charles Behavioral Health Institute, essentially led to them saying, well, if you enhanced our rate, we could build some additional capacity to serve some of these people. They define them as nonviolent, which I think is a good start, because we aren't in the habit of letting violent people out of jail to begin with. And they may have had a violent charge in their history, but they currently aren't showing a propensity for violence. Nonetheless, they still need enhanced security, they still need enhanced care, and St. Charles says, hey, if you have incompetent, unrestorable, and they're languishing in the jail, refer them over to us, we'll evaluate the violence part, and if they're eligible, we'll bring them in for $1,000 a day. Now that's only $200 more a day than what they currently get. And I say only in a somewhat cavalier way of $1,000, but we've paid more. Let me just say that, we've paid more. We anticipate that on average, these folks would stay up to 14 days. Along with the program, we would incentivize treatment providers to go into the hospital and develop, do their intakes, do their evaluations while the person is still in the hospital so they can come out and hit the ground running in treatment, and also help arrange housing, which will be a big issue. To do this, we need to allocate some funds that we get through, and have gotten these funds for years, through the hospital access funds from Ohio MHRSB. They'll pay up to $800 a day. Well, as you just done the math, that's $200 a day short of what we actually need. So we feel we can use the City of Toledo ARPA funds to offset that cost, and then pay some additional dollars for once the Ohio MHRSB hospital access funds run out. So hospital access funds will cover 156 days at $800 a day. The City of Toledo funds will offset that 200, and once those 156 days are done, we'll cover additional days at $1,000 per day. If we are going to be able to do this, we also then have to designate Court Diagnostic and Treatment Center as a pre-screener for St. Charles Hospital. Because they have that body in front of them, they're doing a competency evaluation. They can also then evaluate for appropriateness of hospitalization. Otherwise, we have to bring a third party in, which is typically, most likely Zeph, and it creates a whole nother layer of slowdown. Now, Zeph usually responds very quickly, but days matter here because they're in jail, and currently they're decompensating, so moving them to treatment quicker is a good idea. So that's, we believe the total cost of the program is somewhere around $200,000. It will fund 14 board-funded recipients, and it will also serve 28 others with alternative funding. So this is Medicaid and non-Medicaid. By the way, the majority of the people, as by the numbers I just said, will be Medicaid, and we won't have to pay that $1,000 a day for them. So the idea is allocating the $124,800 from the Ohio Department of Mental Health and Addiction Services Hospital Access Program to St. Charles, which is the motion at the bottom of page 6. And then there's the motion on the top of page 7 that allocates $75,200 from the City of Toledo ARPA funds, pending City of Toledo approval, which we're working on. And then approving the City of Toledo, Court Diagnostic as a pre-screener for St. Charles Hospital. There was a lot going on in those conversations. This is meant to be a pilot, because I'm already anticipating Linda's question, why just Toledo? But we felt that was the best place to work, and that's why we're also requesting to use City of Toledo ARPA funds. Sustainability-wise, if we can prove this works, we believe that we'll be able to receive funding from the state, and we also believe that we can get additional hospital access funds, because that fund used to be $200,000, and we didn't use it all last year, so we got cut down to $124,800. I'm going to stop there. I'm sure you have a lot of questions that I'd be happy to answer.
Makes sense to me.
Speak up, did. Can you speak up?
I said it makes sense to me.
For the ARPA funds, when does that fund actually expire?
Thank you for that, because it does have to be all allocated by December 31st and expended by
The following year.
The following year, so December 31st, 2025.
So the expiration date is for, like, say, for application would be December 31st. For the expenditure is into the calendar year.
The following year, yeah, the whole calendar year after that.
Calendar year as opposed to the state's fiscal year.
Correct.
Linda?
These are only people who are not restorable.
Correct.
And how long will it take court diagnostics to do this?
So, as you know, they're supposed to have their evaluations done within 30 days, correct? And that is what their contract calls for. And so we're holding that to them, and hopefully we'll have quicker. Because these folks are not getting any better in jail. And we're excited about the transfer of, or I guess not the transfer, but the enhanced services that will be in the jail, effective, I guess it was yesterday, or maybe it was 2 days ago. That should help, but it will be a while before things settle down over there. Yes, ma'am.
What does unrestorable? To the extent someone
You're gonna
like that to me.
that's a legal question.
Who's not,
So I will take a stab at it under the
Fair.
understanding that I am talking to an attorney. Unrestorable to me, in my layman's terms, would mean that at no point in the future will they be able to contribute to their own defense.
without, is this treatment gonna help make them?
Nope.
Okay,
No, because otherwise they'd be restorable.
I said sounds good.
okay, all right, so, and the court diagnostic and treatment center, is that the program that a few years back we helped to put together in collaboration with the municipal court?
So that was for the electronic health record that we funded from
Okay.
Ohio Moss
Okay.
funds, which has been implemented.
Okay.
And
Did we help pay for a coordinator or some, am I confusing these programs?
I'm at a,
This
I
would have
don't
been like,
recall.
years ago,
yeah,
like maybe my first, okay, all right.
because you're not saying anything either, so that means I
So
don't
is
think you
this,
recall either.
is this the municipal court?
Toledo Municipal Court.
Okay, so it's not the common police court?
No.
Okay.
No, because if you have a common police court, you can actually get access to the state hospital. These folks cannot. Think Senate Bill 2, folks, outpatient competency folks.
Okay.
These folks are usually not going to get care because they won't stay in jail long enough for anybody to connect with them. And because they're unrestorable, their case is typically dismissed and nobody's really doing anything with them. And I think Linda can attest to that because she experiences that a lot, even at her court.
Unless they, because they're incompetent and unrestorable, their conduct puts them into a different category of criminal activity.
Yeah,
Or alleged criminal activity.
Right, and what we don't want that to do, we don't want their behaviors to escalate to a point where they get deeper into the criminal justice system and then
Okay.
suddenly they have to stay. And like I said, this is a pilot. We think it will be beneficial. And we think that in short order, we will be able to say, hey, this is something we want for all the municipal courts. It may be different populations based upon the funding we have available. We've also suggested some outcomes associated with it. where, so include increased access to private psychiatric hospitalization, reduced jail days, improved engagement in community-based treatment. These folks are notorious for not connecting, I don't know if I should say it that way, but they don't connect with care because they spin in and out of the jail so quickly, and they're not really, they're incompetent and unrestorable, so they're very acutely ill.
And they agree, and then when they leave, they just.
Right, yeah, they agree, and they're not attached to anybody, so nobody knows to go looking for them. Right. So we're just trying to interject a little bit in there to see what we can do.
I have a couple of questions. Is there a cap on the $800 a day funding from OMOS?
Yes, right now there is $124,800.
Well, that's what that is.
That's what that is.
All right.
But we have been told in the past that if we exceed our allocation, we can request more. We don't always, that's why I added the City of Toledo ARPA funds money into that, so that we could have a little bit more and serve a few more people. And, when the funds are gone, we'll evaluate, well, obviously we'll evaluate as it's ongoing, but when the funds are gone, we'll have a case to either continue doing it or not.
Second question is, do you think there's a possibility of any MacArthur money?
There is no MacArthur money, really. I mean, it's all
gone.
It's all been allocated. I think the best we can do with that, and MacArthur, they didn't fund the services that we would typically cover. They did provide some funding for the Opportunity Project and a few other things, but by and large, our system did not receive a whole bunch of money out of the MacArthur.
If anything, it probably was somewhat detrimental because it was focused on getting people out of the jail more quickly so they wouldn't be there for treatment. As it turns out, it's one of the consequences.
I don't know if I would call it as detrimental, but yes, the quicker flow was harder to catch up to those folks. I also do think that there's a lot of damage that is done by somebody who doesn't need to be in jail that ends up staying 3, 4, 5 days when they didn't need to.
Lose their job.
Lose their job, right. Among a lot of other things. So yeah, these are funds that are not in our forecast, but they're not levy funds, and they're an opportunity to braid these things together with little risk on our end, but big gain on the I think on the backside of this.
So we have 3 motions, is that right?
Yep, you can take them all together if you want.
Yep, that's what I was going to suggest. The bottom of page 6, and then there are 2 motions on page 7. Does anybody object to taking them together?
I move.
We have a motion, is there a second?
Second.
Is there any further discussion, comments, questions? All in favor say aye.
Aye.
Any opposed, any abstained, the motion carries. All right, Elijah, Health Officer?
Yeah, so at the bottom of page 7, we just have one health officer renewal this time. Zep Center does the training, they just completed one last week, so we are anticipating a batch of new health officers in the coming months, but for now, we just have the one renewal, and that motion starts at the bottom of page 7 and goes on to page 8.
Any questions or comments for Elijah? Is there a motion?
Elijah, you said that Zep does the training, so to be designated as a health officer, you have to have a training, and that training consists of X amount of hours, and it's a designated agency within the county that does that.
Yeah, so Zep does it because they do the crisis services, and it's the board requires a health officer training as one of the qualifications to become a health officer.
You know how many hours
I think it lasts about 3 hours.
Any further discussion, any further questions or comments? All All in favor of the motion, say aye.
Aye.
Any opposed? Any abstention? The motion carries. All right, Elijah, you also have addiction treatment funds?
Yeah, so the addiction.
Did we make a motion? We didn't make.
Oh, I thought, Did I lose track there?
Yes.
Okay. Do we have a motion?
So moved.
Second. We have a motion and second. All in favor?
I second.
All in favor, say aye.
Aye.
Any opposed? Any abstentions? The motion carries. All right, now we're on to addiction treatment.
Yeah. So the addiction treatment program, or ATP for short, is funding we received from the state to support our 2 drug courts and the participants in those, family drug court and adult drug court. Funding goes to the courts for administrative expenses, and then the common police courts gets additional funding to provide recovery supports through the agencies, similar to what we see in ATP, so housing, kind of emergency food, those kind of things. Task of Northwest Ohio also does the recovery supports for those involved in the family dependency court. Other administrative expenses are the providers that work directly with these, with the drug court participants. So they are on the drug court dockets. They have clients on the drug court dockets. And that those administrative expenses are calculated by the amount of drug court participants the agency has. The state gives us the administrative costs for the common police court and the juvenile court. So those are kind of fixed, but the other ones are kind of decided by the amount of clients they have involved in the courts. And then we put some money aside for purchase of service, so to pay for treatment for those, as discussed earlier, who are not medicated, eligible to receive funded treatment services. We lowered this allocation last year because it wasn't very utilized, because a lot of these, the people in this population tend to qualify for Medicaid, and we have had consistent carryover requests. So we're trying to reduce the amount of carryover requests so we can keep this funding sustained. At the bottom of page 8, it starts the motion for your consideration.
Any questions or comments for Elijah or otherwise?
I
Okay.
move.
So we have a motion. Is there a second?
Second.
We have a motion and a second to recommend to the board the adoption of the motion that starts at the bottom of page 8 for the authorization of $250,000 plus $96,000 in carryover. Is that correct, Elijah?
Correct.
Okay. Any further questions? All in favor say aye.
Aye.
Any opposed? Any abstentions? Please show me as an abstention. All right, thank you, Elijah. Julie, mid-year performance report.
Thank you. Good afternoon, evening. I'm going to walk you through the agency performance report from January 1st, 2024 to June 30th, 2024. The report contains macro level data and as well as some micro level data. So you'll see that there is our priority outcomes framework information in here where you can see some statistics from our county. So you can see that there are a few outcome domains: equitable access to behavioral health services. You can see that it is red because in 2023 there was, for every 250 people, there was one clinician, and now there's 200, for every 220 people, there's one clinician. so that has dropped. And you can see our efforts to reduce suicide and unintentional drug overdose deaths for the count, or for this reporting period. And then you can see our efforts to reduce homelessness for individuals with behavioral health issues, as well as reducing substance use disorder for the count rate. Some of this has remained the same from the last Lucas County Health Assessment. It has not changed and was reported the last reporting period. And then we'll move on to our programmatic review. We currently fund 79 programs, and currently 90% of our programs are on track and 10% were not on track. Apologies, this is a little touchy.
Is that better?
Thank you.
So you made it bigger.
So you can see the programs are broken down between treatment, prevention, and supportive services. 96% of our treatment programs are on track, so 27 out of 28 programs are on track. 87% of our prevention treatments are on track, 13 out of 15. And 83% of our supportive services are on track, so 20 out of 24. And you can see our treatment programs. Our one program that is not on track is the reentry program. Our prevention services that are not on track is the Floating Club, after school program, and the Mercy Lucas County Suicide Prevention Program. And our supportive services that are not on track include ABLE's government benefits, NAMI's Family Navigator, NPI's TAP program, and the Learner's Operation Program.
Did I miss something? Why aren't they on track?
Sure. We can flip to this over here and I can give you more detail. I also have-
I was just curious. I mean, I don't want you to go deep into it.
Okay.
It's gonna throw you off.
No, sure. So in all of our contracts, there is a section called the attachment 3, the programmatic outcomes. So in that attachment 3, when they reported to me for the time period, they did not meet the numbers that they were contracted to meet.
Sure. So basically, they had metrics that they didn't
Correct.
target.
In some of these, in a broad general, there's some staffing issues going on in the agencies where they're having a hard time filling staff positions. Some of that has been resolved. Specifically for the Warner Center, I'm told is illness and COVID has been still an issue there, so they're not meeting the number. They're a little bit falling behind. And as you continue to go through your report, you'll see the resources are for the priority frames outward outcomes. You can see where the information was pulled for that. And then our Appendix A you can see the programs individually a little bit. I'm happy to go through any of them with you, or answer any questions.
Melissa, that Appendix A will give you the answer to the question.
Okay.
Why aren't they meeting? If you see something in red, they were
Okay.
called out. And then there's a note on the outcomes as to what is going on there.
Any other questions for Julie? Comments?
Just a question, the learning club, what is that?
That is a prevention program that focuses on, it's an after-school program for youth who are diagnosed with a mental health issue.
And they are underperforming?
Yeah, so their metrics haven't changed for years, but the intensity of the children have. So they're finding that they're spending a lot more time with the family unit, making sure, trying to get their needs met, and not just focusing on the kids. So they've had to scale back the amount of kids they can serve in order to help the whole family. So we revised that in the next, so this was the previous fiscal year, July 1st, when the contract, the new metric would start. We kept it off track because it was off track then, but we're hopeful that it'll be on track the next reporting period.
Yeah, because I thought that was the question that I saw after school. And I mean, I'm really seeing a clear uptick in services for youth, and I'm just like, wow. Okay.
If you remember, we gave them, we issued an 120-day notice to discuss this program with them because we knew that that was an issue, and so we could revise it for fiscal year '25.
Okay. Thank you.
A lot of their reasons for not meeting their targets is that they didn't reach as many individuals as anticipated. Is that a good thing, or maybe their reach needed to be more, or should, I don't know. It seems like,
Should they go out and get that target audience?
Yeah.
That's what you're saying.
yeah.
So let's also remember, because Elijah just kind of hit on it, this was for the second 6 months of last fiscal year.
Okay.
We issue 120-day notices, which say, hey, we want to talk to you about your programming. And then we make adjustments for this year.
Okay.
So what you're seeing is stuff that we likely have already addressed
Got it.
in this calendar. or
It's just
this
not noted here.
fiscal year. Right.
Doctor?
I see that we keep track of performance which is on track or off track. Do we look at those who are overachievers, who exceed their numbers? Like they're supposed to train 100, they train 105, 110 with the same budget. Should we incentivize that?
So, I'm processing your question, because I don't know what you mean by incentivize. Give them more?
Well, I mean, if a program not just achieve their goal, but overachieve their goal, that wouldn't tell us this, because we can't see these numbers.
So if you meet your outcomes, you are eligible for an increase. If you meet your outcomes by substantial, great, right? But I also start to question, were the outcomes accurate to begin with? So it's difficult to say, hey, we're going to incentivize this, because it might just mean that we had too low of a benchmark to begin with. But it's certainly something we can always consider. I think that agencies would appreciate an acknowledgement of overachieving when it's due, right? We always want to say good things about our agencies to begin with, so.
I would say yes, especially, like what Elijah just said, like next year, because they're helping more families, they may totally, exceed their goal. It'd be nice to, to give them those kudos, if nothing else, that, we recognize you pivoted, and yeah, we don't do anything but acknowledge. I think that goes a long way, so I would agree with that.
So I think we can assign that to Julie to kind of keep track of. That's part of her responsibilities, and we can kind of highlight some of those overachievers.
Good. Okay. Any other questions for Julie or comments? All right, we're ready for open session. Richard?
A lot going on at Government Center. I will be brief. City Council is trying to pull a fast one tomorrow at 2 p.m. at their agenda review. Once again, they're going to look at limiting the number of dogs people can own. What can I say? If dog advocates are aware of this, they'll be at tomorrow's meeting and they won't be happy. But if they haven't heard about it, nothing they can do. And remember, this has not been discussed in the committee. A committee should have public input. It'll be discussed briefly at tomorrow's agenda review, and if they want to, they can put it on the September 11th. It can be voted on. I think it would make a lot of people unhappy. This has not been given any kind of public input. Along those same lines, they will tomorrow look at a moratorium on tobacco shops until at least January 31st of next year. Once again, this doesn't have anything to do with angry neighbors because I attend the Plan Commission meetings, I attend zoning and planning committees and city council. Nobody shows up. And at the Plan Commission, it's standard procedure. They ask, does anybody call? And nope, nobody has complained. It's just the city council has decided they don't like tobacco shops. So they've got a few in the pipeline right now, but at tomorrow's meeting, they'll look at putting it on the agenda, a moratorium on tobacco shops, the special use permit that you would need until January 31st of next year. The Lucas County Jail, or as I like to call it, Durkin's Guest House. I call it that because I keep reading this number over and over that the original cost was $200 million. Not even close. This is from 10 years ago. The jail was supposed to be $142 million. This was a New York firm that came in and studied this. And I want to be clear, this is from October 14th of 2014. Yeah, they said, yeah, we'll give you an expanded mental health facility, an expanded facility where suicidal patients can be kept, and it just never happened. And over the years, you've had so many incidents. I think the most bizarre was probably in 2015. There was a patient there on heavy psychotropic medications. He was discharged, but there was another inmate that had the same name. And over the next few days, 8 different nurses gave that man's medication to another guy that didn't. He ended up in the hospital with severe side effects. His family notified Blade. Blade notified the sheriff's department. They didn't know anything about it. That's a good example of what happens when you use a law enforcement facility for a mental health facility. They have had suicides. They've had sexual assaults. The worst one was probably 2 years ago. The woman, the mentally ill, that they put there and they found her dead in the cell. Every time there's a tragedy, you hear that same argument. Well, we had to do jail. This wouldn't have happened. So here we are in 2024, an election year. It's all caught up in election year politics. Nobody seems to know when are they going to finish this utopian facility, and is it going to do all the things they've been promising for the last decade? The only thing I can tell you is that Unison is no longer the provider of mental health services there. It's Vital Core Health Strategies. I have no idea who they are, but they are now, as of July 1st, they are now assuming control of the mental health services for the people in the jail. So it's hard to get an answer out of anybody over there. And along those same lines, you were just talking about the two municipal courts. They had a safety committee at City Council last week, a substantial discussion about this. All of the council members are concerned about this. And I asked them to consider something. I asked them to consider that, you know, it's really nice to have a fire department that shows up, but sometimes nobody calls fire department until houses engulfed in flames. It's also nice to have smoke detectors because they tell you early on there's a problem. That's what family members of the mentally ill are. They are the smoke detectors. They can tell you long before it's necessary to call law enforcement that there's a problem. Think about smoke detectors, it's easy to forget about. You know, if you sit on the wall and do the job, you don't remember, you got to change your batteries, you got to maintain them. It's easy to forget about them. And with what I have been reading recently, you had the couple in Texas, their son shot up a school a few years ago. This isn't Uvalde, this was before them. There's so many of them, we can't keep track. They were found not liable. But the couple in Michigan, they were found liable. They're sitting in prison. The woman in Virginia whose 6-year-old kid shot his teacher, she got 21 months on a federal charge. The man in Illinois whose son shot up a parade, he was charged with 7 counts of reckless conduct. The family of the man in Wisconsin that drove his car into a parade, yeah, they're in hiding. The most bizarre I thought about, they had the trial of the man who shot up the synagogue in Pittsburgh a few years ago. They wanted to show that mental illness runs in the family. Well, his father's been dead 8 years, but they asked for a court order if they could dig up his father and test him for the schizophrenia issue. This is what we do in this country. We ignore the mentally ill families until there's tragedy, and then we blame them for it. They are the ones that are on the ground, they know what's going on, they're the ones that can tell you a problem long before somebody's got to pick up the phone and call on them. So I asked City Council, why don't you consider a campaign to reach out to families, educate them, let them know they're supported, let them know about community resources, because they are the ones that can prevent that phone call to the Toledo Police that somebody's committed, and of course, when the police show up, they do have guns, and they are trained in the use of deadly force. So I asked City Council, can we take a look at this issue, educating the family members, because they are the smoke detectors and tell you a problem long before the house is on fire. So that's what's going on at City Council. Thank you.
Thank you, Richard.
What else? No?
I have a couple of things.
Go right ahead.
I want to remind everybody that the Recovery is Beautiful Free Family Festival is being held on September 14th at the Werner Center. I think it kicks off at 11 and it'll run till 2. Everybody is invited. We could use some volunteers if you are so inclined. Also wanted to make mention, first of all, thanks to Julie for putting the report together. Well done. Also wanted to mention that you see Mr. Elijah Jones here. He has been promoted to the Director of Programs and Services effective. That's it.
Good. All right, we are adjourned. Thank you.